can introduce themselves. We just really want to thank you so much for taking the time to give us an update and an overview on the CMDs. Charlene York is also on the phone, and we may be joined by 2 other people on the phone who are calling in as well.
Oh, okay.
Okay. Stacy can't, and Sarah's coming in as well? Yeah. Okay.
Hi, this is Lindsay. I just got on from the Beggs Lab at Children's Boston.
Perfect. Fantastic, Lindsay. This is great. Terrific.
Okay.
Excellent. This is Anna Rakowski. Jim Collins is on the line, and so is Charlene York. And Jim, we can see your presentation. I'm going to pass the phone around now so everybody here can introduce themselves in the CMDIR office.
Great.
Okay. Hello, my name is Sabine. I'm a volunteer here with the CMDIR and have a background in sciences, and I'm focusing on the MTM adverse event study that we're hoping to launch sometime soon.
Hi, I'm Emily. I'm also a volunteer in the office. I am working with the MTM study and the CMD checklist.
I'm Rachel. You know me already, the Associate Director of CMDIR.
Hi, I'm Janet. I'm a volunteer here at CMDIR.
Perfect. So that's the crew here. And Charlene York. Charlene, Jim, I think, already knows you, but you might want to introduce yourself so that Lindsay also knows who you are.
Okay, great. I'm Jim Collins. I'm a child neurologist training at Cincinnati Children's Hospital. I did some extra training with Kate Bushby's group in Newcastle at the Center for Life and Institute of Genetics there, and then came back to Cincinnati Children's, where I've continued work in taking care of patients with neuromuscular disorders. And great stories that I first really got introduced to Anne and Rich Cloud at that time with Cure CMD when I was over in Newcastle, and we had some great times. But that's really when I really decided that I wanted to focus part of my career on patients with congenital muscular disease and congenital muscle disease. And so since there has several projects that's been ongoing, including biomarker studies and outcome studies.
Great, thank you.
So do you want me to go ahead and get started, or do we need to wait a little bit more?
I think that sounds great. Why don't we get started?
Okay, great. So Anne asked me to put this presentation together, so I just, my understanding is this was really meant to be a general overview. So I'm covering a lot of the congenital muscular dystrophies here, and I know that if I get into too much detail that a lot of people start to drone off. So I've tried to keep it simple, not knowing everybody's backgrounds, and so that's kind of the approach that I've taken, and I saw that there are some people that are getting into more specifics as the education continues. So that's good. So that's kind of the approach that I decided to take.
Jim, keep going. Lindsay, I just saw that you're not actually logged into the webinar. Do you know how to do that?
Okay,
I just tried logging on through my Mac, but I think I have to download some sort of a program for that, so I'm just on the conference call now. Is that okay, or should I try to figure out the way to do it online?
It's pretty visual, so try to do it online as well. I mean, definitely calling in is no problem. If you are able to download it, that'd be great.
Okay, I'll work on that while I stay on the line.
Download.
You can see my slides, though.
Okay.
Yeah, we can see your slides, no problem.
Okay.
Great.
Good. All righty. Here we go. Let's see. Do I just click on to move forward? Let's see here.
Yeah, if you go to the bottom, or you can use your arrows on the screen.
Oh, this is taking some time. Okay.
And just wanted to let you know that Elizabeth Deschen and Sarah Barnett also just arrived. Elizabeth and Sarah, do you want to introduce yourselves just briefly?
Elizabeth Deschen might be me. I'm not sure.
Oh, okay.
I used her computer after she left, so I think I'm Lindsay.
Oh, okay. Hi, Elizabeth.
Hello,
I know Elizabeth.
hello. I don't think Elizabeth's here. But anyway, I'm on her computer.
Okay.
Oh, that's great. Okay, good. It worked. Okay, go ahead, Jim. Sorry.
Okay, sorry about that. Just in generalities, how we define congenital muscular dystrophy as opposed to like congenital myopathy or others is really related to kind of presentation, which is around birth or early childhood, where the patient presents with a significant degree of hypotonia or weakness, and then based also on muscle pathology, that this classically demonstrates a dystrophic appearance, although we know now that that's not always necessarily going to be the case. It's taking a second for him to go forward. Okay, so what I first wanted to show you is just what a normal muscle might look like in cross-section with an H&E stain. And what you can see there is just that all the muscle fibers are pretty much equal in size to each other, and that the nuclei, these little dark dots, are peripherally located, and there's very little interstitial tissue in between the muscle fibers. But when you look at a patient with muscular dystrophy, this is a patient with laminin alpha-2 deficiency, you can see that there's a variability in fiber size, where you have a big fiber here and some smaller fibers here, and that this pink stuff is really fibrosis and connective tissue that's replaced previous living cells. And you might see, like in this corner, where there might be a degenerating fiber with a lot of inflammatory cells around that. Sometimes you may see splitting of cells, not shown on this slide. There also can be some regenerating fibers that tend to be a little bit darker, where there's more DNA, so it tends to stain a little bit more kind of a darker bluish tinge to it. So in general, these are the proteins that are involved in really keeping the sarcolemmal membrane intact, as well as signaling between the outside to inside the cell and vice versa. And defects in any of these proteins can lead to a muscular dystrophy, and we'll get into more detail as we move forward. But anywhere from proteins in the extracellular matrix involving collagen VI, as well as the laminin alpha-2 molecule, to abnormalities that cause a disorder of glycosylation of the alpha-dystroglycan molecule here, as well as those enzymes are on the inside of the cell, as well as proteins that are involved in processing proteins and calcium control, as well as even in the nuclear envelope. And so we'll touch base on congenital muscular dystrophies that are proteins that are involved in each one of those. So we'll first start off with discussing proteins or gene defects that have a deficiency of enzymatic control, and these are the dystroglycanopathies. Okay, so what occurs in general is basically a loss of alpha-dystroglycan glycosylation, and you can see by this diagram by Reed et al. That shows the normal situation here, where you have basically sugar molecules that are attaching to the alpha-dystroglycan molecule, and with those sugar modalities, that it can then bind to other very important proteins that aid in stability of the membrane, including agrin and specifically the laminin alpha-2. Without those sugar molecules depicted in this picture, that those proteins can no longer bind to the alpha-dystroglycan, and therefore changing how the stability of the membrane, as well as no longer can make contact with the extracellular matrix, thereby making the cell muscle fiber fragile and susceptible to membrane damage with contractions, as well as changes how the cell signals from the outside of the cell to the inside of the cell. So in general, when we're talking about dystroglycanopathies, without hitting each one specifically, because that's a talk in its own right, but that several of there are several common features of the dystroglycanopathies. They tend to be really autosomal recessive inheritance, and it really is a spectrum from severe to mild forms. And each form can involve several different gene types. Typically, with the dystroglycanopathies, there is an elevated creatine kinase, as well as you may see muscle hypertrophy. But this picture just kind of helps visualize how the spectrum of disorders, where you have very severe forms to very mild adult onset forms, but still involving the same enzyme gene products, where Walker-Wahlberg syndrome being the most severe form, where they typically are born very global developmental delay, really have very limited motor movements and have abnormal eye and brain disease, all the way to the mild adult onset, where really they might not have any difficulties except some limb girdle, proximal pelvic weakness without any cognitive involvement. Okay, this is just a slide to show you that there are multiple genes involved in each one of these, and that particularly can kind of go through some of them, like Walker-Wahlberg that we mentioned, one of the more severe ones, that really almost all of the genes involved in dystroglycanopathies that we're associated with can cause that syndrome, and as well as if you move down the line, even the limb girdle phenotypes now, you can also see abnormalities in these genes. The other one I don't have on here is the POMGNT1. But there's still a lot of patients that we don't know what they have, and people are still in process of discovering new genes. Okay, some of the key features that we might see in a dystroglycanopathy, these include eye findings. So these can be eye or retinal malformations. Some people may develop glaucoma and cataracts. This is a picture of a patient's eye showing what a cataract may look like. This patient has Walker-Wahlberg syndrome. Or they can be, the eyes can be completely normal. The cognitive involvement, I think, is pretty fascinating. So it also ranges from severe to normal, where we tend to split it up to severe global developmental delay that you might see in Walker-Wahlberg and muscle eye brain, to kind of intermediates where you might have cognitive delays with brain abnormalities, and then an even kind of milder spectrum where you might see cognitive delays without brain abnormalities. And so what's different about their brains that we can't see on MRI? And then again, there are patients that have normal cognition. These are these are pictures that MRI, I guess, findings, some of the key MRI findings that you can, I put here so you can visualize. And these are some of the more severe that you might see in Walker-Wahlberg, but some of the key things, whoops, sorry about that, my EPIC is showing what I was doing previously, is that the kind of the key features is something called cobblestone lissencephaly. So it's not a complete lissencephaly where the brain is completely smooth, but it does have kind of a cobblestone appearance to it. And there may be something called what we call gray matter heterotopia, which we can often see that is just kind of lateral to the brain surface here. If you look in this in the B panel, where you can see this kind of lissencephaly where there's not much gyration to the brain, and it looks kind of thickened. And just underneath that is another gray area, and that's that gray matter heterotopia. So that this makes kids susceptible to, these migrational defects make kids susceptible to seizures. You can have ventricular megaly, or some patients hydrocephalus, And then you can also have areas of polymicrogyri where, again, migrational defects, where typically tends to be in the frontal lobe. And then you can see in this diagram where the cerebellum or vermis can almost be completely gone or very, very small. Okay, as well as the pons area can be very, very small.
So it's going to be in red cap, but I'm going to have to
so that's kind of the alpha-dystroglycanopathies in general, and then we'll move on to deficiency of proteins in the extracellular matrix. And these include abnormalities in collagen VI, which tends to be located in this extracellular matrix, which I always kind of think of like as the rind on a watermelon or of an orange, where it just kind of keeps everything together in a nice little package. And that interacts with this molecule, which is the laminin alpha-2 or Merosin.
Jim, before you move on, could you just spend 2 minutes talking about, in the dystroglycanopathies, you give a really nice overview of kind of what somebody might look like. What are the steps that would be taken in order to confirm a dystroglycanopathy? If you could just briefly talk about that, that would be real helpful.
Great. Sorry about that. I didn't go into that. Nor did I don't think I touched that on all of them, but I'll mention that as I go along. Thank you, Ann. So the evaluation for each for the dystroglycanopathies, things that are helpful on examination and diagnostics would be, one is if there's an elevated CK. Sometimes that can be 5 to even 15 times normal. Things that can be also helpful is hypertrophy, and then the weakness pattern that we typically see. And so there's a variety of different ways that we can approach that. If clinically everything is fitting, and you may have an MRI, especially if there's cognitive abnormalities, an MRI of the brain might occur, and you might see some of these changes, and with an elevated CK, you might end up just going directly to genetic testing, and all of these genes are commercially available. I usually start, depending on presentation, but the POMT1 and POMT2 genes tend to be the more genes to be more, I guess, predominant, if you will. If you're not sure, the next kind of step is to do a muscle biopsy. And on the muscle biopsy, you may see the appearance of a dystrophic appearing muscle. And then there are protein stains that we can use with immunohistochemistry to look at different proteins. And one of them is that we can stain for the alpha-dystroglycan molecule. And on that, it typically will show a reduced pattern. Sometimes you may see a secondary or partial decreased staining in the Merosin as well. And if I see that in combination with the clinical exam, then that will lead me on into thinking that it's an alpha-dystroglycanopathy. And then I'll proceed with genetic testing. Is that what you had in mind, Ann, or is there other specifics that you were thinking about?
That's fantastic. If you could just talk maybe about the sensitivity and specificity of the antibody stain, whether it's widely available, and given the number of genes that are involved, whether panel or array testing makes more sense, given that each gene now has almost been described with each kind of syndromic and non-syndromic presentation.
Yeah. So yeah, so the antibody is an interesting antibody, and it can be somewhat lab specific. So some labs do a little bit better job than others, but the antibody itself can sometimes be hit or miss. So it's important that the pathologist does controls staining along with the staining of the alpha-dystroglycan antibody. So you have to be really careful with that. And my understanding is that the antibody is not that widely available, and that permissions need to be taken to get that antibody. And you might know that even more specific than I do. But for genetic testing, absolutely, there are some nice panels available now. Athena Diagnostics definitely covers all of the gene tests, and you can do that, as well as Emory has a nice panel now too that is affordable as well. It depends on the clinical exam. I might still do the POMT1 and POMT2, being that seems to be more prevalent. But if it's but also there are some clinical features that might support like FKRP as well. But definitely, if you're not sure, or that some of these clinical exams do tend to kind of fit into each gene, that a panel is definitely worthwhile.
Thank you so much, Jim. That's fantastic.
Yeah. And did you have any other thoughts on that, Ann?
I always like to point out that for the POMT1 and POMT2s, they often are microcephalic, which is a really great clue on the clinical exam, whereas the POMGNT1s tend to have bigger heads. And then there are founder mutations, which might also persuade you to go after POMT1 or Fukutin, for example, depending on the patient's ethnic heritage.
Right, so Fukutin tends to be Japanese inheritance, but they have now seen Fukutin in other populations.
And we just got back from Brazil, where they have a nice case report, because in Sao Paulo they have a Japanese population that's been there for over 100 years, and they in fact diagnosed a patient with Fukuyama CMD in Brazil of Japanese ethnicity and descent. So thank you so much. That was super helpful. I do like to point out that I think the antibody is somewhat problematic and is not widely available, and I think this has precluded a diagnosis for many of these patients who, especially if they have cognitive involvement, end up getting diagnosed as cognitive delay, not otherwise specified, and nobody pays attention to the muscle involvement, which may or may not be present.
Yeah, they may very well just be diagnosed with like a cerebral palsy in general. Okay. Yeah. Great. So let's move on to proteins of the extracellular matrix. So let me just start off discussing the Collagen VI disorders. Again, kind of the theme of congenital muscular dystrophies, it's really a spectrum in all of these disorders. So in this spectrum, we start off with the more severe phenotype, which is Ulrich congenital muscular dystrophy, to the relatively mild phenotype, which is the Bethel myopathy. In Ulrich CMD, this tends to be autosomal recessive, but you can have de novo dominant mutations, as well as in Bethel myopathies. These typically are autosomal dominant, but there are some patients with autosomal recessive. And the genes involved here are the collagen 6A1, A2, and A3 genes. It's involved, here you have the collagen molecule that is made in the skin fibroblasts, and then as a tetramer, and then secreted into the extracellular matrix, where they then bind together in threads, so that if you have an abnormality with each of these genes, you decrease that interaction with each other, as well as making this triple helix. Okay. Again, sharing some common features. Oftentimes there's onset in infancy to childhood, even the mild Bethel myopathies. Many more than often will present in infancy or childhood with contractures. There tends to be progressive contractures. There tends to be a distal laxity of the finger. So in the presence of contractures and laxity, especially Ulrich, where you have maybe more proximal contractures at birth with very bendy fingers, you need to think about collagen 6. Patients may develop a rigidity in their spine, as well as these patients tend to have respiratory function decline that we'll go into more detail. And then patients, especially Ulrich, will have a mildly elevated CPK that can be normal to elevated. Again, this showing the spectrum of disease, where you have Ulrich on the severe end, you have intermediate phenotypes, and then the Bethel myopathy. In general, patients with Ulrich, they tend to to be non-ambulatory and the most severe, or they may reach being able to walk and then lose ambulation within childhood or early adolescence. Those patients with intermediate phenotypes, they tend to continue to walk until maybe late or middle adolescence or on into their early 20s. And those patients with Bethel myopathy may never lose their ability to walk, especially indoors. So it kind of gives you an idea of the spectrum. This is some pictures just demonstrating the distal laxity in a patient with Ulrich congenital muscular dystrophy in the presence of a patient with kyphoscoliosis and rigid spine. These are more pictures of patients with Collagen VI disorders with the huge range of Ulrich to Bethel myopathy. The interesting thing about these patients is they also have not only a degree of, and I didn't mention this previously, but not only in degree of contractures and progression of contractures, but they also have skin abnormalities. And they may present with keloids. Here it's showing a keloid on the patient's knees. Here's showing some of the contractures. And really every joint in the body is susceptible to contractures, including shoulders, elbows, you can see in this patient. Here are the ankles. Again, here's showing an elbow contracture and kind of the Bethlem, classical Bethlem sign with long finger flexion contractures here. And here they're demonstrating this, the long finger flexion contractures. These are patients with Ulrich. In this corner here, patients with Ulrich tend to have this prominent calcaneus that you can see in some patients, and you can really see the distal laxity of the ankles and toes early on, and here again of the fingers. Patients with collagen VI, it tends to be with intermediates and Ulrich overall tend to be fairly slow progression. There doesn't tend to be any cardiac involvement, and cognition tends to be pretty much normal. And patients with Ulrich maybe even argue that they're very bright, very bright children. Excuse me. But one thing that we do need to monitor very closely is that of the respiratory function decline. This is a beautiful study looking at retrospective pulmonary function data with FEC data from 9 centers that Dr. Reagan Foley has allowed us to use, and kind of breaks it down of the respiratory function decline in patients with Bethlem intermediate and Ulrich phenotypes. And in general, you can see that there's a very slow progression in patients with Bethlem, which you might expect given that they tend to be stronger. And the rate of decline in intermediate phenotypes in Ulrich appears to be about the same, although a little bit earlier onset with patients with Ulrich congenital muscular dystrophy, necessitating the need for early respiratory intervention, including non-invasive ventilation, is the first step. And to evaluate this, what we typically will do, we'll either there's several different ways, but some centers do this and some don't, where they will do pulmonary function tests while sitting and lying flat, and if there's a greater than 20% drop in FVCs, that is indicative of some weakness of the diaphragm, and those patients need to get further studying. Some centers don't offer that, and that they may get overnight pulse oximetry, or they may get a sleep study to evaluate the weakness, in helping us to decide whether or not the patient needs extraventilatory supports. Okay. Some of the diagnostics, I think, is really fascinating with this group of patients, because you can do an MRI of the muscles or even ultrasound, and there's a very particular pattern that we tend to see when we're evaluating these patients. And what that typically will show is when you're looking at the thigh area here, is that there typically tends to be more of an increased signal at the periphery of the muscle cell, kind of somewhat sparing the inside of the muscle. Here showing this muscle group is called the rectus femoris, and there's a fascial plane that tends to dip down into the rectus femoris, and that will be bright. And on ultrasound, Dr. Bonneman has called this the central shadow, and can be very helpful when you see that when you're evaluating a patient for collagen VI disorder. And in these two panels, what you typically see is you can see a progression. The first panel here is patients with Bethlem myopathy. The panel below are patients with Ulrich congenital muscular dystrophy. It's a study by Mercury and all. Bethlem compared to Ulrich, there tends to be more diffuse involvement, but you can still see that general pattern of the outside of the muscles being more involved than the inside of the muscle group. And then over time, it tends to involve most muscles. Okay, so when we're evaluating these patients, if you see a patient with contractures, weakness, and distal laxity and possibly skin findings are there, then we highly consider patients with a collagen VI disorder. If you have the means to do imaging of the muscle, but using MRI or ultrasound, that also can lead you down the right path of proper diagnosis. If all these clinical features are fitting together, then you can go directly to genetic testing of all. You want to test all three collagen VI genes. If you're not sure and you get a muscle biopsy, it may show kind of mild myopathic changes to some degree of a mild dystrophic pattern, but can be non-specific. And there are antibodies available to stain for collagen VI. Patients with Bethlem myopathy tend to have normal staining. Those with Ulrich congenital muscular dystrophy can have abnormal staining where you see some reduced staining, but that's not always 100%. And the intermediates are, again, kind of more plus and minus, whether or not you get abnormal staining. So that can or cannot be helpful for you. Sometimes you can get take a sample of the skin, and if there are centers, this is not available to all centers, but some centers will grow the fibroblasts in culture, and then you can stain the collagen VI with immunohistochemistry, and that has really good sensitivity to detect whether or not there's an abnormality in how the collagen VI is arrayed, and there's different patterns that you can see with that. So all of those techniques can be available, but the fibroblast staining is less available. You really have to know a research center or a lab that can do that for you. Trying to think of anything else specific. So those are the most important things. So for patients with collagen VI, as far as treatment options, the best thing to do is monitor the respiratory function as time passes, to monitor for hypoventilation, and then secondary or even first is to monitor the progression of the contractures, and we do aggressive physical therapy with stretching routines that we make the families do daily to help slow that progression down, as well as needing braces and AFOs to help with that. Sometimes surgical intervention can be helpful for lengthening of the Achilles tendon if the Achilles contracture gets too bad and the patients are having problems with walking. Okay, to move on, patients with Merosin deficient congenital muscular dystrophy. This is autosomal recessive disorder of abnormality of the laminin alpha-2, and this is the protein here. It looks like a cross. It binds to the alpha-dystroglycan molecule and to the extracellular matrix, which again helps stabilize the membrane and involved in signal transduction from the outside to the inside of the cell. These patients are rare. Prevalence is about 0.6 in 100,000. Clinical, some key clinical features shown here in this child from that was described by Golick and I can't speak, Derige. I apologize if I'm saying that incorrectly. But patients can have facial weakness and malocclusion of the teeth. Their tongue can be somewhat hypertrophied, and there can be a flattening of the nasal bridge. There tends to be a degree of a weakness, approximately, especially in the upper extremities where they are unable to raise their hands over their head. And you can see in this child that she already has some degree of contractures at her elbows and potentially at her fingers. You can see that she has contractures here at her hip flexors, potentially at her knees and ankles. And they tend to have a lot of truncal axial weakness as well. And here you can see that she's unable to have flexion of her head against gravity. Overall, if you look at all patients with Merosin deficiency, majority are not able to get to the ability to walk, although there is some variation to that. There can be rigid spine in these patients with developmental scoliosis over time. And in a subpopulation of patients, there seems to be about 30% of patients that develop seizures later in life, typically around adolescence or maybe late childhood. And these patients often do have respiratory function decline, and depending on how weak they are early in presentation, they may require ventilatory support early on, and then as they gain strength, they may not need it for a period of time. Patients with Merosin deficiency also can have abnormalities in their brain. This is a picture of an MRI T2 image showing the bright changes that you see in the white matter. And this typically will occur after the age of 6 months. So most patients after six months of age, you can see this pattern. Some patients will have, a smaller percentage of patients will have posterior fossa hypoplasia of the vermis or cerebellum. There can also be some migrational defects, especially the occipital lobe. Some patients will tend to have larger head circumference, but that's not always the case, and it may be because of the changes that we're seeing in the white matter itself, which may be more fluid collection. Okay, this is a study that we did looking at respiratory function, again, similar to the Collagen VI and other muscular dystrophies, that over a period of time that there tends to be more of a restrictive respiratory pattern and some degree of weakness of the respiratory muscles in the diaphragm. And so what was not known is what the rate of decline was. And so similar to the study that Dr. Foley and all had done, we decided to do the same thing for Merosin deficient patients. And then this diagram is just showing what the difference in rate of decline is in patients that are walking and not walking. So patients that are walking, their rate of decline is much slower than those patients that never had the ability to walk, and that makes sense because it helped the overall strength pattern that we see. What we don't know is exactly when these patients need ventilation, and not all of these patients are on ventilation, so there seems to be some variability in that. Okay. So for patients with Merosin deficiency, I apologize, I didn't put this on any of the slides, but for the particular workup, what we typically see will be an elevated CK, somewhere between 1,000 to 3,000 range. And in patients that fit this clinical profile, especially with early onset within the first few months of life, and maybe some mild facial weakness, you can almost you can kind of go right off the bat that this may be a patient with Merosin deficiency, and you can go to genetic testing. If you're not sure, a muscle biopsy can be very helpful, showing a dystrophic appearing process, as well as there are stains of antibodies for the Merosin itself. This can be a little tricky. If it's completely absent, then you can be pretty confident that this is going to be Merosin deficiency, and you can do the genetic testing. If it's partially absent, that's a little bit trickier, because if you remember when I talked about the patients with alpha dystroglycanopathies, they may have a secondary deficiency in Merosin. And so it's important to also stain for alpha dystroglycan, but as Anne noted, that is not always available, and the antibody itself is not always work properly. So doing genetic testing in Merosin first is the way to go. If you don't find appropriate mutations, then to probably do a panel in the with the alpha dystroglycanopathies would be the next step to go.
Jim, I have a quick question. Have you ever seen the white matter changes that you typically see in a Merosin deficient patient in a patient who ends up being a dystroglycanopathy?
Yeah, in patients with the dystroglycanopathy, the white matter changes tend to be a little bit more patchy, whereas Merosin, it tends to be this nice confluent appearance to it. So I have seen some patchiness in particularly a couple patients I've seen with POMT, I think that POMT2 mutations, kind of more patchiness to it. But you can see the white matter changes.
Thank you very much. It's an amazing presentation here, so thank you.
You're welcome. All right, let's move on to deficiency of proteins of the sarcoplasm. Historically, this is related to, with congenital muscular dystrophies, related to patients with selenoprotein N1 mutations, but recently it's been described of patients with congenital muscular dystrophy onset with ryanodine receptors of the RYR1 gene. And these guys like to live in the sarcoplasmic reticulum down here, and I'll go into a little bit more detail as we move forward. So selenoprotein N1 is, again, somewhat of a spectrum, and can be in the muscle pathology can be quite different between them, but a lot of common clinical features can occur. Selenoprotein N, so now they call them SEPN1 related myopathies versus kind of the historical rigid spine muscular dystrophy. So some of these changes can be kind of mild myopathic features, or you can have dystrophic appearance. Some, as I have here, this is a picture of oxidative enzymes stained, and you can see these kind of multi-mini cores within the different fibers. You can have a congenital fiber type disproportion can be seen, as well as not shown here, something called Desmond-related myopathy with Mallory-like bodies. But thank goodness that the clinical presentation tends to be similar to help us with our diagnosis. So selenoprotein N1 is involved in oxidative reduction reactions, specifically through the glutathione pathway, and it's involved in calcium regulation, and seems to be important in the RYR1 receptor function and calcium flux. And if you have abnormalities in the selenoprotein N1 pathway, that leads to increased oxidative stress and abnormality functional, I can't really talk about abnormalities in the function of the calcium channel RYR1, shown here in this nice diagram developed by Arbogast. So I think this is very helpful. This is the normal situation here, and then this is a patient that has the kind of more of a pictorial effect of what might be happening in a patient with selenoprotein N1 deficiency. There is some evidence that selenoprotein N1 may be important in developmental of myogenesis as well. And kind of keep this picture in your mind when we talk about patients with RYR1 when we move on. Clinical presentation, these patients really can present early onset or again, a spectrum to later onset. And in early onset may just be kind of generalized hypotonia. But there tends to be a predominant axial muscle weakness, especially with head control. So they can get dropped head where they have difficulty raising their head against gravity, especially neck flexion control can be very, very weak. And their proximal can have proximal weakness, especially the upper extremities. And these patients, they may even have normal developmental motor milestones as the lower extremities tend to early on not to be as affected. And patients tend to be able to walk on into adulthood. This is a patient by Shara et al. That depicts a kind of a typical presentation how the child may appear. Kids tend to be very skinny. They kind of have kind of shoulder and kind of generalized atrophy of the muscles, and this child is showing how rigid his spine is in appearance. Notice he is able to hold his head up against gravity, but he probably would not be able to, if he was laying in a supine position, able to raise his head above gravity. Also, you might know that some atrophy of the muscles, especially in the medial groups. And we'll look at what the muscle might look like if you did imaging. So this is a patient with selenoprotein N1 related myopathies, and if you do imaging, you may see this pattern which shows more of the medial groups tend to be involved. This muscle group here, which looks very light in appearance, is the sartorius muscle, and that seems to be, early on, seems to be the muscle first affected in the legs, as well as the adductor muscles here may also be involved. And sometimes you may see, and this is the lower extremity in the thigh area, I'm sorry, in the calf area, that the gastroc muscle here may be affected as well. So you can kind of see a pattern as we're going through the different congenital muscular dystrophies that getting muscle imaging can be quite helpful and very and help you lead you into the right direction. These are kind of more the majority of patients that you might see, but sometimes it can be a little bit more diffuse involvement and not as helpful if you see the patient later on in life. For workup for these patients, one, the clinical history is very helpful. It can, the SEPN1 patients can look similar to patients that we'll talk about with RYR1, as well as some patients with lamin AC mutations can look similar. So getting muscle imaging can be helpful. Getting muscle biopsy is not as helpful, although you might see some of the particular changes that we talked about early on. If you saw cores with this kind of picture, you might think of RYR1 and selenoprotein N1 and go for those gene mutations. Otherwise, there's not any specific antibodies that you can use at this point in time to help you. But going off of clinical presentation can be helpful, especially if the patients present with early respiratory failure. I didn't talk about that, but kids with selenoprotein N1 typically present very early onset respiratory failure, so it's important to when you see these patients to get a sleep study. So related to the SEPN1-related myopathies, there are the RYR1-related myopathies. Again, there's a clinical spectrum with the RYR1 gene defects where you can see multiple different varieties of pathology, including central cores, multiple cores, central nuclei, predominant, even emeline rods. Or you can see a marked type 1 predominance where most of the muscle fibers are type 1 muscle fibers that are pretty uniform in appearance. This is related to gene defect of the ryanodine receptor. If you remember when we talked about the selenoprotein N1, it's in the sarcoplasm, and it's very important in calcium metabolism. Patients with RYR1 gene mutations are at risk for hypermalignant thermia and syndrome, so you have to caution patients that are going under anesthesia. And patients with RYR1 mutations without central core or other type of myopathy may have malignant hypothermia syndrome not associated with myopathy. These tend to be autosomal dominant, although there's recent reports of autosomal recessive associated with the severe congenital onset. Okay, again, a spectrum of disease can present in infancy with weakness and hypotonia. There can be motor delays and being not able to walk until, say, 3 or 4. Weakness pattern tends to be more lower extremities than upper extremities, which is a little bit different than what you saw in patients with selenoprotein N1, which tends to be more upper extremity than lower extremity, and so that can be helpful. But there can be neck weakness, and sometimes patients will present with some facial weakness or ophthalmoparesis, but that's not as typical. Congenital onset, you have to monitor for kyphoscoliosis and respiratory insufficiency. Okay, so when you evaluate these patients, their CK, again, may be normal to mildly elevated, similar to selenoprotein N1. But the muscle and ultrasound shows a different pattern where typically the lateral muscle groups tend to be more affected, and you get sparing of the rectus femoris, and that can be very helpful. And when you look at the lower legs and the calf area, the soleus muscle here tends to be more affected than the gastrocnemius muscles, so that can be helpful. So based on these patients, it's really, I think, for me, difficult to go directly to genetic testing unless I have the muscle imaging. So when I see these patients, I usually will get some type of imaging, either ultrasound or MRI to look for this pattern. If I'm not able, these patients will end up usually getting muscle biopsy that can be very helpful, especially if it shows the central cores or one of the other typical patterns. And then based on that, you can direct your genetic testing. Okay, and so the last group that I want to talk about are deficiencies of proteins in the nuclear envelope, and this includes lamin AC. So this is important in gene splicing and transport of genes that are involved in specific genes that are important for gene expression. So this is a fascinating gene to me because it can, a defect in lamin AC can cause just a variety of different neuromuscular disorders ranging from Charcot-Marie tooth type abnormalities with hereditary peripheral neuropathies to limb-girdle muscular dystrophy to Emery-Dreifuss muscular dystrophy, dilated cardiomyopathy, as well as a hereditary lipodystrophy abnormalities and progeria with increased aging process. So it's just a fascinating gene, but within the muscular dystrophies it can range between congenital onset to the less severe limb-girdle onset. For the congenital muscular dystrophies, these tend to be de novo dominant type mutations and present at birth or early childhood. CK can be normal to mildly elevated and may present similar to the SEPN1 patients where they have a high degree of neck flexion and extension weakness, a lot of axial weakness, and their upper extremities are much more involved than the lower extremities. Importance in monitoring these patients are really the cardiac arrhythmias, because you can have sudden onset death for these patients, even at an early age, and so it's very important to get 24-hour Holter monitoring early on in their evaluations. As similar to other patients with congenital muscular dystrophies, they have progressive contractures and may develop a rigid spine. So you can see that rigid spine in all the congenital muscular dystrophies is not as specific as we used to think when we first described the rigid spine muscular dystrophies. And these patients also have progressive respiratory insufficiency and need non-invasive ventilation. This is some really nice pictures that Susanna Kiana-Roy had put together of patients that they had seen with L-type congenital muscular dystrophy in her first description of these patients. You can really see what I've talked about of a lot of axial neck weakness in this child here. They tend to be very skinny, so you have to monitor nutrition. Make sure, really, and that's the case with all of these patients with congenital muscular dystrophy. Most patients really have a difficulty with gaining weight, so nutrition is a very important aspect in their general care. And you can see here also scoliosis and some rigidity to the spine needs to be monitored. Patients' workup for LCMD also can include muscle imaging. This is a nice paper, again, by Mercury, where they looked at patients with rigid spine of different disorders. And this is a patient with lamina AC mutation. And what they saw was that there can be a variety or variability between muscle groups that are affected within the thighs. But in general, almost all patients showed preference to involvement of the medial gastroc muscles that you can see here, and here. So if you see kind of an isolated medial gastroc involvement, that can be very helpful in addition to your clinical and your clinical exam and your history in these patients to go for genetic testing. Okay, so just to kind of overview that, even though it's a heterogeneous population, there are some there are some features that do cross between the different groups. And in each group, there is a spectrum of disease from more severe to mild phenotypes and may not even present even on into adulthood. And your clinical exam can be very helpful when you're trying to decide what type of congenital muscle disease they have, depending on the weakness distribution, being either upper extremity or lower extremity or axial weakness. CK, as you saw, can be very helpful. Patients that tend to have a higher elevation in CK will tend to be more likely seen in patients with the alpha dystroglycanopathies. Those with about 1 to 3,000 typically are going to be seen in patients with Merosin Deficiency. And those that are kind of normal to mildly elevated really can be seen in any of the other congenital muscular dystrophies that I talked about today. So if you're considering Collagen VI or RYR1 or STEPN1 or any of those, but you see a CK of greater than 1,500, it's probably going to have to be something else going on there. Muscle imaging, as you saw, can be extremely helpful with the different patterns seen. And as we monitor and evaluate these patients, we always have to consider their respiratory function, their cardiac function, orthopedic issues, including scoliosis and contractures that can affect their mobility and their respiratory function, and getting these patients mobility devices to help them have a functional and I guess happy life, giving them independence and so forth. Okay, and then obviously patients with cognitive development, abnormalities of cognitive development, we're going to make sure that they get the services they need with speech and language devices, and of course monitoring for seizures. Okay, so that's the end. I just want to thank you guys having me talk to you. I hope that this was helpful, and I want to thank Cure CMD and Ann for everything that they've done for me.
Awesome. That was fantastic. I'd like to open it up for questions, and I was wondering if anybody on the phone has any questions or anybody here has any questions.
I have a question. This is Charlene. Do you, as a doctor, go back and look at the muscle biopsies over the years just to see how the dystrophy is progressing at all? Just curious.
You mean as getting another biopsy later on in life, or just reviewing maybe what has been done previously?
Getting another biopsy later on in life.
Yeah. At this point, we typically do not, just mainly because it's, you're academically it would be nice, but you're putting risk into patients that have respiratory weakness, and so we typically do not. Although you could do a local. But we feel that there's increased risk to that more than you would gain from benefit. I think now with the muscle imaging modalities that we have at hand, it's a much more helpful tool. As you could see with the Collagen VI disorder patients, you can really see that. Let me see if I can find that for you. You can really see that progression over time as you move forth. So really probably any more you can monitor that progression with muscle imaging.
Okay, great.
That brings up a great point, Char, because in the past, and maybe you can speak to this as well, Jim, for endpoints in clinical trials, they might consider doing repeat muscle biopsies, but muscle imaging, even though it's not quite there yet, is now being studied in order to determine if a drug or an intervention actually improves the muscle fibrosis that one can pick up on MRI.
Yeah, obviously the muscle will show you a much greater detail, and you can do biomarkers within the muscle itself if you do get that. They have done that for other clinical therapeutic trials in Duchenne muscular dystrophy, although they found that there has been some problems with even measuring dystrophin because in larger trials that the muscle might have been handled different ways and immunohistochemistry done different ways, and so that can or not necessarily always going to be that helpful to you. Muscle imaging, as Ann pointed out, people are looking at that. There's a Florida group that's looking both Duchenne and Collagen VI, and not only looking at fibrotic changes, but also kind of chemical changes and fluid shift changes as time progresses in each child. So that may be very, very helpful in outcome studies.
Great. Well, Jim, we really want to thank you so much for your time. This was a fantastic presentation, so well organized and so clear. I think it's really kind of, everybody here in the room feels that it's really helped them kind of make sense of all the disorder and chaos of CMD.
You're welcome. I apologize not having for the diagnostics on there, but anyway, we talked about it.
No, we talked about it. We had a favor to ask you. Rachel has recorded this just so that we can go back and look at this. Would you be okay with if we put the recording on the Cure CMD website and as well on the CMDIR as a tool and a guide and a resource for people to use in teaching? Would that be appropriate?
I think so. I think let me make sure that I have all the references on there appropriate. And then I'll give that to you once I get all the references. So I want to make sure I give credit where credit is due. But yeah, otherwise, yeah, absolutely.
Oh, that would be great. That would be fantastic. Thank you very, very much. And then I will be in Cincinnati. I think I'll be seeing you right on Friday.
Yeah, I hope so. I'm on service, but it should work out. I should be there most of the day.
Fantastic. Okay, sounds great. Terrific. Thank you, Lindsay, for joining us, and Sarah for joining us as well. And thank you again, Jim, and looking forward to seeing you and Char later on this week.
Okay, great.
Okay, bye-bye.
Thank you. Bye.
Bye.